I'm going to actually do something mildly different. I'm actually going to show a case that I haven't done yet, that I saw recently, that I thought was very interesting, and figured I would take the opportunity to harness the brain power of the panelists to get their thoughts about this case. And then if we have some time, I'll just touch briefly on some of the didactic aspects of working up a painful total knee. These are my disclosures, nothing that is specifically relevant to this talk. So this is a 78-year-old female who came in with a complaint of a painful left total knee arthroplasty. She had a right total knee replacement done 5 years ago. There were no perioperative complications. It was done at an outside facility. No perioperative complications. She did well for the first 3-4 years. Her complaints were relatively mild. She said she had, low-level pain, but had started noticing some more swelling over about the past year. She denied any constitutional symptoms. She had no issues with infection perioperatively. You can see she has well-controlled diabetes, some lumbar stenosis. She has rheumatoid arthritis, but does not take any medications for it. So that's important. She doesn't take any biologics or prednisone. Only takes high blood pressure medicine, and she has no allergies. She's skinny by our standards. Pretty much a normal exam. Her knee felt, stable, but she did have an effusion. It wasn't warm. She had no erythema. And her exam was actually relatively benign from a pain perspective. And I thought her knee was actually relatively stable. So let me just run through her x-rays here. These were her immediate post-operative films. July 10th, 2015, I thought looked pretty good. There was nothing I could really throw any stones at from this perspective. I thought they did a good job of the cemented posterior stabilized total knee. And here were her 2-year post-op x-rays when she was seeing her surgeon. And at that point, she was still asymptomatic, doing great. And then I'm going to jump forward to the x-rays when I saw her, and I can flip back and forth. And here she is at 5 years out. So she's 5 years out from a modern cemented total knee, good polyethylene. And this is how she presents. Again, modest pain and, some increasing effusions that were going on. And the surgeon that saw her was certainly concerned about this and wanted to send her down. So, Jonathan, what are your thoughts about this? I thought it was a little bit unusual 5 years out. Talk to me a little bit about how you might manage this.
Well, I'm staring right at that femur defect, where that came from. So I was taught that in osteolysis happens later, right? And anything that looks like osteolysis that's before that is an infection. So that's clearly number one on my list. I also don't understand why they used a revision tibia with a short stubby stem instead of just the primary tibia, which is basically the same length. I don't think you get much length. You maybe get 2 centimeters difference on that, but I don't know why they did that in the first place. But I'm very concerned about that osteolytic lesion, ESR, CRP aspiration, 100%. Maybe even an MRI to see what's going on there. Make sure it's not like a tumor or...
Yeah, so that definitely came up on on my list too. Infection, she's 78. Could it be some kind of primary or metastatic tumor? Bolo, anything else that you can think about? I think certainly
no, not really.
It's
it's fascinating. It's a fascinating case. I agree with what
we've seen a couple of these, Brian, where they got like the poly dislodges. And they maybe leads to early wear. So I can't really zoom in on the lateral, but if the poly sometimes looks like it subluxed a little bit,
it's a really good thought. Matthias, anything that
I was just thinking, it's modern poly, but we're seeing some bad batches out there in some design. So I wouldn't rule it out completely, but I think you have to, as Jonathan points out, it's infection unproved, painful knee replacement is infection until you prove otherwise.
And that's kind of what we were thinking. We were thinking infection, lysis, possibly tumor on the list. I was going back looking at these x-rays. Can you guys see my mouse? I feel like I see this quite a bit in knee replacements. as they get a little further out. It's not really a radiolucent line. It's almost just a little radiosclerosis right there. And I don't know if that's indicative of anything. I certainly, if I was seeing it 2 years post-op, probably wouldn't have batted an eye, if I saw that. And I think, Jonathan.
The other thing that can happen is you can have a loosening, and just the pistoning can cause these osteolytic lesions. It doesn't have to be bad poly, but movement. Yeah. And we know that fluid pressure will cause osteolytic cavities.
Yeah, we've seen quite a bit. We have historically seen quite a bit of that behind implants for a specific system, where there may be poly where present, that you see, but also the femoral effect or the amount behind the femur can be pretty devastating.
Yeah. Yeah, I was thinking about, as Matthias mentioned, that hydraulic effect, and Jonathan, also you brought up the poly issue as well. I think this, I don't use this implant design. I've used it in some patients with allergies. I think it has a great locking mechanism, but sometimes it is a little bit finicky to put it in, I know, with those tabs across the back. So not to complicate things, but she had a completely stone cold normal SED rate CRP. I aspirated her knees as I do all of my knees. And I mean, she only had 400 nucleated cells. She had 30% PMNs, and this weird thing came back on her culture at about, 7 days. So anything different you guys would do? I called my ID doc. He didn't know what it was. So anything that you guys do different at this point? I mean, this is pretty conflicting data. I will say my index of suspicion for infection was low just based on her history and her exam, but obviously that radiographic appearance kind of, raised my eyebrows a little bit.
I don't know, I guess reaspirate would be the technical answer, right? To see if it grows.
Yeah, so I did. Yeah, I repeated her aspiration, and I think I actually may have sent her off for like next gen. And, sure. If that doesn't show anything, then I know I feel pretty good, because that usually shows everything. So I was pretty happy that came back with no growth. The interesting thing about this is we had another patient in clinic on this exact same day who was aspirated and grew this exact same bug from our same lab. So I think it was probably a contaminant, because we had two patients that grew this, and I hadn't seen it in 15 years. So I think it was something that was going on in our lab. Interesting enough, but so repeated it, got same low numbers, and cultures didn't grow anything. So I felt pretty confident that it probably wasn't an infectious etiology. So I didn't actually order this. This came when she came in for a referral. I guess it's not a horrible idea. I guess it maybe if you're looking at metastatic disease or something along those lines. But Jonathan, how routinely are you getting bone scans in patients for your workup for painful total knees?
Only if something's doesn't make sense to me, right? If there's no clear answer, I think it's just one added benefit where you can do the bone scan plus maybe a tagged indium scan to see if you have weird information like you're having. So I think I would have absolutely ordered that if this stuff was just becoming weird like you're doing.
Yeah, so not routine use.
I think it's helpful. I'm a little bit of a dinosaur in that regard. I still use it because I can look at that image and I can say there's something wrong there. I don't use it for infection, but I can say, guess what? That is a hot scan. That shouldn't be the case 5 years out. That's loose, and that bone is something's going on there. The negative scan is also helpful, and you rule out everything. Your X-rays look good. The bone scan's negative. The MRI plus or minus is negative. That's when you go, well, there's nothing I can fix here. And if there's nothing I can fix, the last thing you want to do is operate on them. Here, it looks like there's something real going on, both on your X-ray and your bone scan. I can interpret this a whole lot better than some of the MRIs, even though Hollis Potter's been trying to teach me to do it for 20 years. This I can see. This is hot. This is a problem.
Yeah, absolutely. Absolutely. And then let me just also show you, so we did get a CAT scan, just to kind of look a little bit further. Hopefully this will play here. So I'll just run through this. Bolo, take a look at this as you kind of go through on these kind of axial cuts there. Get a little bit of scatter as we get a little further across there. But that's
cool.
It's a pretty big hole.
Big hole.
It's a pretty big hole.
Yeah, My experience seeing that again is always a polywear issue. I totally agree with the infection concerns, but
yeah,
that's polywear for some reason. I don't know. Maybe I'm missing the point.
And it's a slow process because it has a nice sclerotic ring. Infection, it's got to be pretty indolent. But if you look at it, it's a beautiful sclerotic ring. This has been going on a while. The bones had a chance to react to it and try to encapsulate it.
So that Matthias
well seated.
Less likely to think about infection than with that well corticated rim. The slow process is trying to remodel itself. Yeah. Okay. So as I said, I haven't done anything yet. I actually just saw her probably within the last month for the first time and just kind of completed this workup. So I get to ask each of you to kind of put your nickel down on what your thoughts are about doing this. Any other tests that you think would be helpful? I did have someone that was concerned enough about it that suggested doing an open biopsy of the lesion. And then if we are going to offer her surgery, part of the challenging part with her is that she's mildly symptomatic. She's got an effusion, but she doesn't have a ton of pain, right? So, and she's not overly excited to have surgery, but I think, she's kind of gotten scared now when we put her through this big workup and shown her x-rays and her CAT scan and all that stuff. So if you do decide to do something, how are you going to do it revision wise? Liner with just grafting of the defect. And if so, what kind of graft are you going to use? Do you take off the femur? And then how do you deal with that big hole, or is there a chance you'd ever pull anything out? So Jonathan, I'll start with you. Anything other tests or things like that, or what's your trigger to operate on her?
Just two questions. Do you know if that was oxinium component or not? And do you know what kind of cement was used?
I don't know the type of cement. It's a great question, but it was oxinium.
Okay. So I'm not sure I need any other tests here. This in my brain categorizes as an impending something really bad happening. So it may be more simple to do something now than when she breaks that and then it's a distal femur replacement.
Sure.
So I think she forces our hand into surgery despite her lack of symptoms, her mild symptoms. I would go in there. I'm familiar with this revision system, so I would go in there with the plan of, looking at the femur and ready for just a femoral revision. You already have a revision tibia, so you can put in whatever polys you need to there. Have cones or bone graft. You kind of need the whole gamut there. Maybe even some plates in case you think it's going to break off on the condyle. But
yeah, good point.
I'd be ready for anything.
Good point.
I don't think I would do just a liner exchange, unless you got in there and you can see clear evidence of like third body wear and the liner was just getting destroyed. The femur was completely rock solid stable.
Okay.
That'd be great if you could, but
yeah,
that's like the best case scenario.
So Bola, what's your plan A, B here?
Yeah, I mean, I think the tibia looks fine. I'm going in. I would have if it's this weird, I don't disagree. I would have our tumor folks just look at the x-rays. We actually found one time believe it or not, I mean, it had some calcifications, but same setting, it was chondrosarcoma in a patient. And actually one of our PAs, senior PAs, figured that out and had the wise decision to have it evaluated first. Because that would obviously change your reconstruction. But I would have at least plain films visualized, and this is femur with a cone, once confirmed, this is polywear for whatever reason.
Okay. Matthias?
I prepare for femoral revision. I think this femoral component will come off. I think it's probably a combination of loosening. But, the one thing I would get is I would get an MRI with some sort of metal suppression, because the nice thing is it can tell you it may have been a loose poly that's rattling around in there, even though she doesn't have instability, and that can certainly cause this. And it'll help in terms of the tumor workup as well. If something looks funny, then it may steer you a different direction.
Okay. So if it was just, something unusual with the poly, would you then still consider leaving the femur on?
No, I think you can have better access taking off and putting a new femoral component.
So taking the femur off, grafting that area or putting a cone.
Yep.
Putting a cone
and then a stemmed implant, short stem cemented.
Short stemmed implant. Yeah. Okay. Yeah, so that's kind of what our thoughts are going into this. Maybe I'll give you an update at next year's year's course. Or you may see it sooner. So I want to make sure I leave Bolo enough time. Let me run through just really briefly here the workup. So part of the problem with painful total knees is you get this long differential diagnosis, which oftentimes leads to a costly and lengthy workup. So I'm a big believer in trying to keep things simplified. You've heard this in a lot of the cases today, and this is kind of the rule we follow, which is assume that every painful total knee is infected until proven otherwise, because the treatment is so different and you certainly don't want to miss anything. So I order Sedrate and CRPs on everybody and have an extremely low threshold to aspirate people's knees in the office, because I think it gives me a lot of good information. Always emphasize this, which is don't forget about the hip. We've all seen these cases of patients that come in with painful total knees that look good, they're stable, and they hurt. And in fact, it's the hip above that really is the source of their symptoms. Again, we tend to get long alignment films on everybody, so we get a free picture of the hip at the same time, but really just a simple exam to move them around in the office can give you a lot of information. I think you have to understand the mode of failure before you take on a revision. So as I've heard people say, pain is not an indication for a revision. Pain is a symptom. You really have to have a good, strong indication for why you're going into that knee. And if you are just revising a knee simply for pain, overall, and this has been shown in multiple studies, Mike Mont was one of the first ones to show that your overall success rate for an exploratory surgery is going to be very low. Again, categorize your modes of failure early versus late, although in this case, you might argue osteolysis was more of an early cause for that case that I just showed. I think we tend to get away from our history and physical and an over-reliance on testing and not sitting down and talking to the patients and doing a good exam. And that can really give you the underlying cause of all of these problems that are listed here. Again, a little bit of an emphasis on the spine as well. It doesn't cost anything to take a good history and a physical exam. I think plain radiographs and an aspiration before I go to nuclear scans and CT scans are very helpful. And again, radiographs can help you outlay osteolysis, malalignment, instability, loosening, patellar subluxation. You can get a lot of information off of just keeping your evaluation of the painful total knee simple. So I'll go ahead and stop there and make sure we leave enough time for Bolo. Thank you very much.